Ladies and gentlemen, I would like to have your attention for the next speaker, of which I'm very glad she's here, because she wrote an article in which she took some physiotherapists and some radiologists, and she asked them to scan a shoulder, and then she looked at the outcome of these scannings. So please, Marloes.
Okay, thank you.
Tell us.
Well, I'm very excited to be here, and I would like to thank the organizing committee for inviting me to present our study. This study was a cooperation between the Erasmus Medical Center, the Amphia Hospital, Avans University of Applied Science, Maastricht University, and the University of Amsterdam. And it was financed with a CRA grant. I would also like to apologize in advance, as I'm not a native speaker. So please forgive me if I'm being unclear or use phrases like Louis van Gaal. Because, yes, well, an English presentation is different cook for me. So, I will do my best. I would like to start with this clip to explain why we actually conducted this study. Well, the prevalence of shoulder pain is really high, and it is actually one of the 3 most common musculoskeletal disorders in general practice. Patients report to have, besides having pain, patients also report to have functional disabilities ranging from opening a jar to work-related tasks, and therefore present an economic and social burden on society. Patients want to know what's wrong with them, and eventually a large amount of patients visit a physical therapist via their GP or direct access. PTs are used to work with history taking and physical examination to provide a diagnosis, which is essential to provide the patient with an accurate treatment plan, correct information about his prognosis, or if medical care is warranted. Several systematic reviews, however, have concluded that the diagnostic accuracy of physical examination, including widely used tests, isn't good. Diagnostic ultrasound is increasingly used by PTs. However, little to nothing is known about the reliability and validity of diagnostic ultrasound when it's performed by PTs. A recent survey conducted by Wendy Scholten, one of my colleagues, stated that a large amount of patients, 50 to 85%, already received a diagnostic ultrasound when they are referred to secondary care. However, most medical specialists feel there are more disadvantages than advantages when PTs use diagnostic ultrasound. They assume there is a high amount of false positives, and they actually do not trust the results. And they perform the ultrasound again themselves. The diagnostic accuracy of diagnostic ultrasound when performed by medical specialists is really good, especially for full-thickness tears, with pooled sensitivity and specificity both above 90. Among others, Mathieu Rutten, our chairman of today, concluded that the reliability between radiologists is excellent. And he also concluded that the learning curve is relatively short, 100 ultrasounds. For partial thickness tear, pooled specificity remained high, but sensitivity decreased, and kappa values range between 63 and 79. For bursitis and calcification, results seem promising, according to Ramon Ottenheim in his systematic review, but they should be interpreted with caution, as they are based on small studies and not on pooled data. Our aim was therefore to assess the inter-rater reliability, the agreement between physical therapists and radiologists on diagnostic ultrasound on patients with shoulder pain in the following 4 categories: full thickness tear, partial thickness tear, bursitis, and calcification. So, the real question is, do we actually see the same? Are we looking at an old man or a younger female? The recruitment. This reliability study is part of a larger prospective cohort study called the Shocodip project, which stands for Shoulder Complaints and Diagnostic Ultrasound in Physiotherapy. We invited many PTs, mostly from the southwest region of the Netherlands, to participate in our entire Shocodip study. Only PTs that were trained to use diagnostic ultrasound could participate in our reliability study, but we also had some other demands. They should have finished their diagnostic ultrasound course more than a year ago, and they should have made more than 100 ultrasounds of the shoulder after they finished their diagnostic ultrasound course. Radiologists were invited from several hospitals, and they were all experienced and specialized in musculoskeletal ultrasound. We also had some demands for the equipment of the PTs. It had to have digital beamformer technology and a minimum transducer frequency ranging between 5 and 10 megahertz. Because the literature states that this is the most commonly used transducer frequency, and a transducer frequency of 7.5 megahertz seems to be the recommended transducer frequency to scan musculoskeletal tissue. Both the PT and radiologist were trained to use the International Scanning Protocol of Jacobson, which is focused on anatomy, technique, and scanning pitfalls. And it is, we used it to standardize the procedure, but with respect to daily clinical care. The protocol did not include presets such as gain and depth and transducer frequency, and is less strict than others. Patients with shoulder pain were eligible if they were over 18 years of age and adequately understood the Dutch language. Patients were excluded in the presence of serious pathology such as infection, fracture, or cancer if they received previous surgery and if they received diagnostic imaging techniques such as MRI in the previous 3 months. The procedure. The patient visited a physical therapist. The PT checked whether or not the patient was eligible, if he met our in- and exclusion criteria, and explained our study. If the patient wanted to participate, he signed informed consent. And after that, the patient, as well as the PT, followed the usual diagnostic pathway, of which ultrasound could be part. In case an ultrasound was made, the research team received a standardized outcome form. In case the PT who made the ultrasound met our selection criteria, we contacted the patient and asked the patient if he wanted to participate in our reliability study and if he wanted to receive a second diagnostic ultrasound. If the patient wanted to participate, we contacted the nearest hospital to check for availability within 1 week because of progression bias, and if we could make an appointment, we did send a letter to the radiologist with a hypothesis after history taking, because radiologists are used to work with hypotheses. Both the patient as well as the radiologist were blinded for the outcome of the diagnostic ultrasound. Well, our 4 categories of interest were of course included in our standardized outcome form, but we also had a consensus meeting between radiologists and PTs to check whether or not some diagnostic labels should be integrated in our standardized outcome form if they are frequently used in daily clinical practice. This resulted in a total of 10 primary diagnostic outcomes, of which our 4 categories of interest were part, and they were based on 24 diagnostic outcomes. Our 4 categories of interest again: full thickness tear, partial thickness tear, bursitis, and calcification. And the other 6 diagnostic primary outcomes were tendinopathy, biceps tendon tear, subacromial impingement, osteoarthritis of the AC joint, no pathology, and other. In case of a full thickness tear, partial thickness tear, calcification, or tendinopathy, the PT could specify it by adding the affected tendon. And the 24 categories were only used to reflect daily clinical care, and these were categorized into these 10 primary diagnostic outcomes for this study. Our analysis: we were interested in the demographic characteristics of both the patient and the raters. We wanted to calculate Cohen's kappa, which is a measure to assess the reliability, the agreement, and we calculated an overall kappa based on our 4 categories of interest and a kappa for each of the categories of interest. We also calculated specific positive and negative agreement for these 4 categories of interest, and we calculated the prevalence for each of the 10 diagnostic primary outcomes. We assessed We performed subgroup analysis based on experience and training. Experience was based on more or less than 200 ultrasounds of the shoulder, and training was divided between basic and advanced. All PTs were trained to use diagnostic ultrasound of the shoulder, but some PTs followed specific additional courses and were therefore labeled as advanced. And the subgroup analysis was based on the overall kappa to check whether or not it was higher or lower between the PTs that followed additional courses with the radiologist. Cohen's kappa is a measure that adjusts for the agreement that is expected by chance, and for the interpretation of the kappa values we use the following criteria of Lendes and Koch. A kappa value of 0.81 to 1 is almost perfect agreement, and a kappa beneath 0 is poor agreement, and everything in between. Specific positive and negative agreement are regarded as essential for clinicians, and its use has been recommended by Ricky de Vet. Especially specific positive agreement seems to be important in this case, as diagnostic ultrasound is mostly used to label the patient with a diagnosis, and agreement about the pathology being present is therefore essential. Specific positive agreement can be calculated in the following way, with the following formula: 2A divided by the total of 2A plus B plus C, which stands for the number of patients labeled by both clinicians as having the condition, times 2, divided by the number of patients labeled by both, times 2, or one of the clinicians as having the condition. The results, again, do the radiologists and the PTs see the same? Is this a vase or are these two faces? A total of 65 patients participated in our study and received both diagnostic ultrasounds. The mean age of the patients was 56 years of age and 54% were male. The median duration of shoulder complaints were 12 weeks, and they had an NRS of 6 and a SPADI mean score of 51. In this study, a total of 13 PTs and 9 radiologists actively participated. These 13 PTs were able to include patients that received a second diagnostic ultrasound, with a median of 3 patients per PT. All participating PTs and radiologists were male, and about half of the PTs were highly experienced, and over half followed additional courses and were therefore labeled as advanced. Well, we were mainly interested in kappa and agreement, and we found an overall kappa of 0.36, which is fair agreement. And for full thickness tear, physical therapist diagnosed 6 patients as having a full thickness tear. Radiologist felt there were 9 patients that had a full thickness tear, and only in 5 cases they both diagnosed the patient as having a full thickness tear. So only once the PT labeled the patient as having a full thickness tear and the radiologist didn't, and in 4 cases the radiologist diagnosed the patient as having a full thickness tear and the PT didn't. This resulted in a kappa value of 0.63, which is substantial agreement. We found a kappa value of 0.10 for partial thickness tear, which is slight agreement. A kappa value of 0.28 for calcification, which is fair agreement. A kappa value of 0.54 for bursitis, which is moderate agreement. Well, the overall observed agreement was 80%, and we found higher specific negative agreement compared to specific positive agreement in all diagnostic categories. We found overall specific negative agreement of 86% and overall specific positive agreement of 51%. This indicates that this agreement was more often found in diagnosing a patient with a certain pathology as compared to ruling the presence of a pathology out. Subgroup analysis. We found higher agreement for both the highly trained and the more experienced PTs compared to the less experienced and trained PTs. The more experienced PTs that made more than 200 ultrasounds showed moderate agreement with the radiologist compared to only slight agreement with the radiologist for the PTs that made less than 200 ultrasounds. PTs that followed additional courses showed moderate agreement with the radiologist, and again, PTs that only followed basic courses showed slight agreement with the radiologist. The prevalences of tendinopathy, biceps tendon tear, subacromial impingement, arthritis of the AC joint, no pathology, and other, and its implications. The prevalence of calcification was highest, 22%, based on how often both the PT and the radiologist placed the subject into the same category. The prevalence of bursitis and calcification was substantially higher according to the radiologist opposed to the PT, 25% versus 11% and 48% versus 31%. Radiologists felt there were more patients without any pathology than PTs, and PTs found there were more patients with an impingement compared to the radiologist, perhaps because of professional background. Our conclusions. Well, at this moment, it is not plausible to integrate diagnostic ultrasound into everyday clinic or into the PT educational program. Only full thickness tear showed substantial agreement, but this was borderline, and the overall kappa was fair. Subgroup analysis indicated that both education as well as experience could make a difference. However, the agreement was still limited. This could, however, be promising for the upcoming future. We found higher specific negative agreement compared to specific positive agreement, meaning there was more disagreement about the pathology being present than absent. Well, our results are less promising than the results described between radiologists, but our study population was different. All of our patients were from primary care, perhaps with less severe pathology, resulting in a lower pretest probability. Our scanning methods were standardized, but the outcomes were not described in detail, meaning that we did not describe what the PT or the radiologist should have seen on the screen to label a patient with a certain diagnosis, for example, partial thickness tear. The Jacobson protocol is less strict than others, but to our knowledge, no published scanning protocol has proven to be superior towards others. This agreement often consisted of one clinician labeling the patient as having a partial thickness tear, and the other clinician labeling the patient as having a calcification or a tendinopathy of the same structure. This difficulty has been described before. Diagnostic ultrasound is a relatively young diagnostic technique for PTs, and development within education, equipment, and learning curves of PTs could eventually lead to a higher level of diagnostic ultrasound of PTs. Therefore, it is important to acknowledge there might be a possible added value of diagnostic ultrasound in the future of the physical therapy profession. Implications. At this moment, it seems PTs use diagnostic ultrasound mostly to label patients with a certain pathology. Based on the overall agreement and the low specific positive agreement, it seems that diagnostic ultrasound performed in primary care should not be integrated in their diagnostic clinical practice yet. One of our studies showed that most PTs use diagnostic ultrasound after history taking to provide a diagnosis and do not perform physical examination afterwards. So their diagnosis is solely based on history taking and diagnostic ultrasound. Perhaps it could be useful to add physical examination, as the results of just diagnostic ultrasound should be interpreted with caution. Diagnostic ultrasound could perhaps be used in a slightly different way, as there is a high level of agreement between the radiologist and the PT in ruling pathologies out. The PT could perform a diagnostic ultrasound to examine if there is no contraindication to loading the tendon and there is no limitation in the level of exercising this tendon based on the physiology. So, for example, to rule out the presence of a partial thickness tear. Subgroup analysis showed that both education and experience lead to a higher level of agreement with the radiologist, so training and the learning curve seem to be useful. At this moment, however, conclusions based on the results of the diagnostic ultrasound of the PT only should be interpreted with significant caution. Well, I would like to thank you for your attention, and of course I would like to thank all of my hardworking colleagues and all of the PTs that participated in our study, as well as the radiologists, of course.
Thank you very much. Marloes, are there any questions from the audience? Over there.
The quality of equipment? No, we only had some demands for the equipment of the PTs concerning the digital beamformer technology and transducer frequency. But of course, there's a difference between the equipment of PTs and radiologists in cost, for example. So there is a difference between higher-end Philips equipment or Toshiba or other types of equipment and the equipment that PTs use. But we found 2 studies that investigated whether or not the equipment does make a difference on the reliability. And these 2 studies showed that portable ultrasound machines and higher-end Philips both show that the reliability between it is good. But they only measured muscle thickness and length, so I'm not sure if it also doesn't affect the agreement if we're looking at pathology-based diagnosis. But yeah, well, it could be that it influenced our results, but it is daily clinical care, I guess, because we cannot afford a higher-end Philips in our practice, in our clinic. So I think we compared both machines as they are in daily clinical care. Did I answer your question? Okay, thank you.
Yeah, in the study you compared the physiotherapist to the radiologist, but did you also control the ultrasounds of both by an independent person?
I'm not entirely sure if I understand your question correctly, but
well, you only compared the physiotherapist to the radiologist,
yes,
but you didn't control if there was an independent person who looked at those pictures separately.
Well,
because there can be the difference between looking at the pictures, and maybe they had there was a problem with both of the ultrasound.
Okay. No, we didn't. We didn't check whether or not the radiologist was right. So we didn't perform an MRI or anything like that. But we only used the diagnostic labels for which the diagnostic accuracy is already known for radiologists. So radiologists are capable to diagnose a patient with a full thickness tear because pooled sensitivity and specificity. Sorry?
That's what you presume.
Yes,
that's what you presume.
Well, it's not. We base it on the literature. There are many studies that have shown that radiologists can perform it in a good way. It's valid, it's reliable. So yes, it was an assumption, but it was based on the literature. Okay.
I'm not a radiologist or a physiotherapist, so I'm going to be completely independent.
Okay.
However, I just want to ask the question, does it really matter? Because there's increasing evidence that a lot of shoulder surgery has very tenuous evidence for use in shoulder pain. Where it could matter is a full thickness tear.
Mm-hmm.
So my question to everyone here is, does it really matter if you don't diagnose a partial thickness tear? If you can see a full thickness tear, then that might change your practice.
Yeah.
But if you look at, there's a physiotherapist in London called Jeremy Lewis, who has done lots of research on conservative versus surgical options for surgery, and has found that, in fact, if you compare the two, there's not much difference between surgery and rehab. Do you have a comment about that?
Thank you for your question. It's very relevant, and I partly agree with your statement. I think that from its origin, physical therapists are used to work with the ICF, and we make a more functional approach instead of a medical diagnosis. So you're absolutely right, and our treatment plan does not differ greatly. So you're absolutely right, but diagnostic ultrasound is increasingly used, and we have to be careful that it is used and PTs think they are looking at the truth.
The question is, does that matter?
Mm-hmm.
If they're not diagnosing minor pathology, does that matter to the outcome of the patient? It seems that the recent evidence suggests that it doesn't matter.
Yeah,
No.
well,
The answer is it does matter.
Well, not according to
No.
not according to the recent randomized controlled
Yeah,
trials.
I know the figures, but there are other studies who show that, especially in younger patients, because I think you have to stratify on age, especially younger patients. From these, we know that the tears will progress, and eventually we will become full thickness tears.
You have to read the recent.
Yeah, I've seen it.
You've seen it.
But that's one study, and I've seen some others.
These are randomized controlled trials.
I know. So there's discussion on this subject, and
Okay.
you're right that you bring it in because does it matter? In most of the cases, I think it doesn't matter. If you have somebody of 60, 70, 80 years old with a partial tear, yes, of course, there will more than 60% have tears. The question is, are there problems? And if yes, do they come from the tear or from the bursa or anything else? So it's far more complex than a discussion about a partial tear.
but I actually think that when you do use diagnostic ultrasound and you say to a patient that it is a calcification, you have to be sure it is, or you don't have to perform it at all if you think it doesn't matter. So, but thank you for your question. Are there any other questions, or shall we start the discussion? Okay.